Hi, this is Andy Turnbull from the Royal Bournemouth Hospital and Optegra, and welcome to part 2 of this lecture on managing astigmatism with toric IOLs. So in this part we'll cover toric implantation and the postoperative management. Just a quick recap of part 1. We covered why astigmatism matters and showed that toric IOLs are an effective treatment option. We should be aiming to target the minimum residual cylinder, and we discussed patient selection, particularly when you're starting out with torics. The importance of precise measurements was emphasised, as was the role of SIA and the posterior cornea. We looked at various calculation methods and formulae and concluded that currently the Barrett toric calculator, along with the integrated K calculator and predicted posterior corneal astigmatism, offers the best outcomes in virgin eyes. So we're now halfway through the toric IOL process, and we now need to choose which model of toric lens we're going to use. There are several toric lens models available, and they all have their pros and cons. The ideal toric IOL should be rotationally stable, have good optics, no adverse effects inside the eye, be easy to implant, be available in powers to correct low astigmatism, but also have options for very high or low powered IOLs in extreme ametropia and astigmatism. So rotational stability is the thing we probably focus on most with toric IOLs, and this is related to both the lens material and haptic design. Hydrophobic acrylic IOLs have been shown to have the best rotational stability, and it's thought that this is because stronger adhesions develop between the capsule and the lens in the early postoperative period. Now the RCOphth is particularly tacky, and in fact even during the initial surgery it can be difficult to rotate the lens because of this stickiness that you encounter. The other benefit of hydrophobic acrylics is that they are less prone to opacification, and particularly in the context of patients that may require secondary surgery such as endothelial transplantation or vitrectomy. The other key aspect is haptic design, and this is all to do with the amount of contact that there is between the haptic and the capsular fornix, and companies have come up with several different designs to try and achieve this. Brian Lee and David Chang from California published a comparison of the two most commonly used toric IOLs, the RCOphth and the J&J Technis, looking at the axis at the end of surgery compared with at the first postoperative check. They found that the rotational stability was significantly better with the RCOphth, with 10% more rotating 5 degrees or less, although both lenses performed pretty well. Mean rotation was less than 4 degrees with each lens, and the repositioning rate, as you can see, was low. A further comparison of hydrophobic acrylics was presented at a Hoyer symposium at Escris in 2018 and showed that the Hoyer Vivinex may have even better stability than the RCOphth, with a mean rotation of just 1.5 degrees and no rotations greater than 5. These results had some similarities to those of Lee and Chang, again showing better stability with the RCOphth compared with the Technis, with fewer big misses with the RCOphth platform. So of the toric monofocal IOLs that I have personal experience with, these are my preferred options. The RCOphth is what I used throughout my fellowship with Graham Barrett and is certainly his top choice due to the rotational stability. The lens material is imperfect, however, with glistenings being relatively common, and this is something that's been widely talked about, but they often don't seem to bother patients too much. The Technis from J&J is a very good option, but as we've seen, the stability is not quite as good, and the rates of PCO are also reported as being higher even with meticulous capsule polishing. For extreme cases, Rayner offer a fantastic custom-made service whereby pretty much any power of toric IOL can be ordered. The downside is that they are hydrophilic, and as we've seen, that leads to less rotational stability and also an increased risk of opacification. In terms of future directions, Alcon seem to have resolved the issue of glistenings with a new hydrophobic acrylic material used in their Clarion platform. At the time of writing, The Clarion is not available in toric powers, but it will be in the near future, and this could well be a game changer in terms of combining the rotational stability that Alcon have achieved with a lens that performs better optically. So now we've chosen a lens and we know where it's meant to go. How do we go about achieving that? Well, this is where toric marking and verification of the alignment comes in. Accurate preoperative marking of the axis while the patient is upright is critical to successful toric placement, and this is because the eye rotates when patients lie flat. The amount of cyclotorsion encountered when a patient lies supine is variable, but it can easily be 10 degrees or more, which, as we've learnt, translates into a 30% reduction in toric correction. Now, there are as many toric marking techniques as there are toric surgeons, so this is one aspect where it's not a bad idea to experiment with different options and find one that suits you and your practice environment the best. One of the more common options is a 3-step method whereby ink or a needle is used to mark the limbus at 0 and 180 degrees, and this can then be verified, if you like, with various apps that are available on smartphones, such as the Spirit Level or the Toricam from Graham Barrett. These reference marks are then aligned relative to the required toric axis, and again there are various devices to enable this, with the Mendes gauge probably being the most widespread. And then further marks are placed intraoperatively to guide toric placement, and this is usually done with ink, but again there are options. The Thermodot from Bobby Osher is a bipolar cautery device that creates a small ink-free mark, and the advantage is that the marks are very precise and long-lasting, although I found that ink is usually more than adequate for this purpose. There are some devices that can achieve all of this in one step, and we'll see an example of that shortly. And something that's also come in fairly recently and is being increasingly used are image-guided techniques. So this is where a reference image of the eye is captured preoperatively, usually on the biometry machine, and this is then imported to an intraoperative verification system such as the Verion from Alcon or the Callisto from Zeiss. An image of the eye is again captured intraoperatively with the patient lying down, and this is then matched up with the reference image, and this allows a virtual overlay to be superimposed to then guide the toric implantation. We'll talk a bit more about that a bit later on. So I'll just go into a bit more detail about Graham Barrett's 3-step marking technique, in which he uses the Toricam for verification. So this is a really simple and cheap, but above all very effective method of toric marking. So firstly, the patient is positioned upright. The limbus is dried and then marked at what you perceive to be 0 and 180 degrees. You then open up the Toricam app on the iPhone and occlude the patient's fellow eye, which aids their fixation with a target, which is usually the light on the iPhone. You then hold the phone vertically and with as little tilt as possible. The exposure and illumination can be adjusted on the app, and it's then worth taking several images because it's very difficult to get this absolutely perfectly aligned first time with the patient moving, with your hand moving. It's quite it can be a bit of wobble. So I always take multiple images in which I'm aiming to rotate the phone to align the red bar that you can see here with the ink marks, and also align the central reticle with the first Purkinje image. I then go back and review all the images that I've taken and select the one that best identifies the orientation of the reference axis. And this has been shown to significantly improve the accuracy of freehand or slit lamp reference marking. So I'll just demonstrate that technique in this video now. Can you just if you just stand a little bit further back there and then just hold an index finger up, that's great. Nice and kind of there, that's great. chin up a bit there, Eric. Nice and straight. That's brilliant. Well done. Okay, so eyes wide open. That's really good. I'm just going to come pretty close, but just keep nice and steady. And keep looking at her finger. Well done. Lower over your brow there. And I'm just going to check where those marks are. Yeah. So sit up really nice and straight, Eric. That's great. That's brilliant. Okay. So now if I can just get you to look straight at the light on the phone. That's brilliant. Well done. Okay, so that's about 3 degrees. Good. So then once you've marked the reference axis and confirmed where it is with the toric arm, you then need to align the required toric axis relative to this. This video shows how that can be achieved with the dual axis marker from Duckworth and Kent. So as you can see, we've marked the axis 0 and 180 with ink. We then rotate the small outer markers to align with the reference axis, so we know how to offset this based on what we've found with the toric arm, and we then rotate this larger gold blade to be at the required axis of the toric lens. It's important that you then dry the ocular surface with a spear, particularly around the areas that you're going to be placing the marks, in order to get the most precise mark possible. So then we've inked the underside of the gold blades, and you align the corneal light reflex with the centre of the dual axis marker and push down firmly to achieve 2 nice marks which will guide alignment, and these marks almost always last the duration of the case. So in a study by Lipsky et al., a relatively inexperienced toric surgeon used the dual axis marker in one hospital and then the Mendes gauge in another. All other aspects of the surgery and preoperative marking were identical, and it was found that the dual axis marker led to significantly more accurate postoperative alignment than the Mendes gauge. So this is an alternative option where the marks are all made in a single step, and I'd like to thank Ahmed for allowing me to include this video in the lecture.
Okay, so you can actually show, I'm going to be actually showing how I put these glasses on. And these glasses provide a point of fixation and some magnification. Now this little magnifier here allows me to look at the one-step marker and set the axis on the marker by looking through these, this magnifier here. Looking through my little magnifying lens. I'm setting the marker to my steep axis here. I can move the magnifying lens out. Now, I'm going to look at the white light over here, okay? All right. I'll just cover this one. Now look at with your right eye actually here. Yeah, like that. Good. So I'm going to come forward a bit. There you go. Keep head straight.
Yes, I will.
Apply the one-step marker. I'm basically using the light reflection from the cornea to center the mark here. Press for 5 seconds or so. The thumb bob here allows gravity to essentially centralize the device. There we go, and there's a mark there nicely. Beautiful. So we'll see in the OR, but I have now marked the axis at 65 degrees. We've provided the point of centration and we can now center the lens and provide it the right axis all with one step.
So image-guided systems are increasingly popular and help automate the process. The concept of iris fingerprinting was developed by Bobby Osher in 2010, and this led to the development of the Callisto from Zeiss and the Verion from Alcon. Now, both devices are very similar in their accuracy, and there's some evidence that they may be slightly more accurate than manual marking. In this study from 2017, they found that the toric misalignment was 2.8 degrees on average with manual marking, compared with 1.3 degrees with the Verion, although this had no impact on either postoperative refraction or unaided distance acuity. Now, the thing to be aware of with these devices is that they're not foolproof. Errors are definitely possible. In my fellowship practice, we would routinely use both the Verion and the Callisto, depending on where we were operating, in conjunction with manual marking with the three-step method that I showed you just before. And we then compare the two, and it was reassuring when both methods matched, but occasionally they didn't, and we usually found that it was the image-guided system rather than the manual marks that was wrong. And there's also a financial implication, as these devices are very expensive, so my advice would be to focus on being accurate and efficient with a manual marking strategy. So once we've got the lens in the correct position, we need to make sure that it stays there. So Inoue et al. Found that most toric rotation occurs within the first hour of surgery, but in reality it probably occurs even earlier than this. So these are some particular risk factors to look out for. Axial myopes and those with large white to whites often have more voluminous capsules, meaning that rotation is more likely. The capsule is also usually larger in the vertical meridians, so when the haptics need to be orientated at 6 and 12 o'clock, which is when we're correcting with the rule cylinder, the lens is also more likely to rotate. There's also a theory that patients with healthy zonules are prone to early rotation, and this is because with weak zonules the bag is loose and more able to effectively shrink wrap around and configure to the shape of the haptics. And I've heard this being compared to trying to slide along a wooden floor as opposed to a loose rug. Of course, all this leads to a perfect storm in younger myopes in whom all of these factors may be present. So here are a few tips to help achieve rotational stability. As we discussed earlier, the choice of IOL model is important. The rexis must completely overlap the optic, and increased contact between the capsule and the IOL can reduce the risk of rotation. So for this reason I tend to make a smaller than usual rexis when I'm doing toric cases, and then ensure thorough polishing of the lens epithelial cells to avoid capsule phimosis. Just on that topic, some people suggest leaving the LECs to increase fibrosis and prevent IOL movement, but in reality this process doesn't occur for several weeks, which is long after the time that the IOL will have shifted. Hydrophobic lenses tend to unfold quite slowly, so although they're very good for their rotational stability, you do need to ensure that the haptics are fully unfolded before completing the case. So I tend to leave the lens a few degrees short of where I want it to end up, then remove all the viscoelastic and rotate it to its final position. Rotating anti-clockwise is okay before the haptics are fully unfolded, but after that it may put excess strain on the capsule and the zonules. So if you do end up a few degrees beyond the required axis, it's best to rotate it all the way around again. I've heard some surgeons refer to this as the circle of shame, but it should really be considered a lap of honour, as it demonstrates your commitment to ensuring the best outcome for your patient. So once the lens is in the correct position, I push down slightly to encourage it to adhere to the posterior capsule, and after this you of course need to ensure watertight wound closure, as if the AC flattens or shallows postoperatively, then this can cause the lens to rotate. Having said that, I do tend to leave the eye slightly softer than usual. I feel that this allows the capsule to almost shrink wrap around the lens to some extent, rather than leaving the eye more tense, in which case the capsule may be more widely open and then the lens can rotate. So leaving the eye slightly softer than I would normally is something that I tend to do routinely. Obviously, it's important that the patient minimises any head movements for the first post-operative hour, particularly when they're getting up off the operating bed, and then they need to be advised not to rub their eyes as well. So if the lens appears particularly mobile, or if the patient's got the risk factors that we discussed previously, then you can consider placing a capsule tension ring or a Henderson ring, which is like an undulating CTR. And both of these act as mechanical impediments to IOL rotation. You can see here, this is a picture that was from Steve Safran in New Jersey, and it's a complicated case obviously, but it's just showing how the modified CTR that's in place is actually serving as an impediment to the lens rotating. But despite our best efforts, some patients will have residual astigmatism, and we need to know how to manage this. So although outcomes are good with toric lenses, the process is not perfect and errors do happen. So patients should be made aware preoperatively of the limitations of the toric lenses and the potential need for enhancement in the form of IOL rotation, IOL exchange or laser. And this should mean that in the rare cases where enhancement is required, it comes as less of a surprise for the patient and is not viewed as a complication or failure. So firstly, you need to try and identify the source of the error, and this could be at any stage along the chain. And as I said at the beginning, each of these is cumulative, so a small error at each step turns into a very large error by the end. So it's worth looking again at the preoperative measurements, making sure that the biometry was accurate and reliable, ensure that there weren't any transcription errors, and this is a particular problem with using online calculators where lots of transcription is required and it's very easy to make a mistake if you're not concentrating. Double check the notes to make sure that the correct lens was implanted and that the lens was orientated into the correct position according to the preoperative calculations. It's often a good idea to repeat the biometry and measure the postoperative Ks and compare these with the preoperative Ks, because this gives you an accurate assessment of the SIA in that particular case, and it may well be that the Ks have changed from pre-op to post-op more than you would expect. The posterior cornea is important, and it may be that the formula that you used didn't account for this appropriately. And if after all of this you still can't find an obvious reason, then there are other intangible factors. The formulae are not perfect. We don't get it right every time, despite everything seeming to be perfect. But before wading in, you need to check if the patient is happy with their vision, and if they are, then you don't have to do anything. If they're unhappy, then our options are either to rotate the toric lens, implant a new lens either on top or in exchange for the original lens, or perform a laser ablation. And in order to work out what is needed, we need an accurate refraction and measurement of where the toric lens is currently sitting. Rather than just rotating the lens back to where it was originally intended, you should put the required data into either the Barrett RX calculator or the Berdahl and Harden toric results analyzer at astigmatismfix.com, and then find out where the optimum position for the lens is based on what is currently known about the eye's refractive status. So in terms of timing for toric rotation, I'd suggest about 3 to 4 weeks post-operatively. So this ensures refractive stability and allows some capsule fibrosis to occur, which will help prevent further rotation once you realign the lens, but without leaving the patient unhappy for longer than necessary. So although some surgeons rotate lenses at the slit lamp, I think this process is best done in theatre. I'll show you a video shortly, but in essence you need to mark the current axis of the toric lens and then mark the target axis. So you don't have to do any preoperative marking in terms of the 0 and 180, because that is now irrelevant. You're purely wanting to move this lens that's already in the eye to a position that gives a better refractive result. You should aim to use the original incisions if you can to avoid introducing any further SIA, and then fill the AC with viscoelastic. Ensure the IOL is free of any capsular adhesions, and then rotate it to the required position. And if you feel that the lens is going to remain unstable for whatever reason, then at this stage you could also consider an additional device such as a CTR or Henderson ring. So I'd like to thank John Berdahl for allowing me to include this video, which demonstrates his technique for IOL repositioning.
Toric T9 IOL that has rotated. You can see the alignment mark inferiorly, and we focus to the alignment marks on the toric lens and back. This lens has rotated approximately 30 degrees. So we bring the patient back to the operating room and we perform an aura, which confirms that there is about 4 diopters of residual astigmatism. Then we mark the cornea, marking the point where the IOL is currently and where we want to rotate it to. Previously, we used our website, www.astigmatismfix.com, which calculated that the IOL should be rotated approximately 30 degrees clockwise. Once we make our initial marks, then we find 30 degrees away and mark that precisely. One thing that's nice about marking the current position and where you're going to mark to is that you don't have to take into account the effects of cyclorotation. Clearly you would have to when you originally implant the IOL, but not once it's in place. We go through the original incision and insert viscoelastic to inflate the capsular bag. It's nice to use the original incision because you're not inducing any new surgically induced astigmatism. Once the haptics are freed from the posterior capsule, the lens can be rotated. This lens has only been in place for approximately a week and a half, and so it's quite easy to rotate. I prefer to rotate in the clockwise direction because it's a bit easier to rotate, and now you can see that the alignment marks on the IOL are consistent with the ink marks on the cornea, and we're in good position. Viscoelastic removal is performed with irrigation and aspiration. In this case, I did not put new viscoelastic behind the IOL because the IOL rotated so easily. Once that viscoelastic is removed, the wounds can be hydrated and the centration of the IOL can be confirmed. In this case, you can see that the capsule rhexis is not covering the entire IOL. The IOL is repositioned so that it is covered by the capsular rhexis, and a repeat aura is performed, confirming that there is now about 1/2 a diopter of residual astigmatism remaining.
So that draws to an end the toric IOL process. So just to finish off, I thought I'd just quickly mention the potential drawbacks of using toric lenses. So the meta-analysis by Kessler et al. Found, unsurprisingly, that using toric lenses leads to an increased likelihood of a secondary procedure. Interestingly, they also found an increased incidence of retinal tears, which was attributed to the increased manipulation required to ensure accurate toric alignment intraoperatively. And both of these should reduce as you gain in experience with toric lenses. There's also an inevitable impact on workflow. It is much quicker and easier to implant non-toric lenses. The formulae are simpler, the surgical flow is quicker, and the post-operative management is less. But as we've seen right at the start of this lecture, if we don't use toric lenses, we're actually letting down a high percentage of our patients by committing them to a visual outcome which is less than their true potential. So I think the take-home message is don't let any of these potential drawbacks put you off. So to summarise this two-part lecture on managing astigmatism with toric lenses, we're not currently doing enough for astigmatic cataract patients, and I'd recommend that you perform toric calculations on all patients regardless of their anterior keratometry, as this is the only way to accurately predict the patient's post-operative residual astigmatism. We should be targeting close to 0 or very low residual with the rule cylinder, and if we're doing things correctly, then 80% of our patients are going to be toric candidates. We should use at least 2 and ideally 3 devices for keratometry, and then put these into the K calculator to get the best result. We need to have a handle of what our SIA is, but if we haven't yet established that for ourselves, then use a value of 0.1 and don't vary the axis of your incision. Ideally use a temporal near clear corneal incision, but don't vary it from case to case, as this will just muddy the water. You need to understand the posterior cornea and how the various calculators go about correcting for this, and the best option at the moment is the Barrett toric calculator with integrated K function. All toric IOLs are not created equal, so again there are pros and cons to each of them, and it's worth knowing about these before choosing which lens we're going to implant. It's essential that we mark the toric axis accurately and then place the IOL precisely. Despite our best efforts, we're not going to get it right every time, so we do need to have strategies for managing residual astigmatism. So here are the references which may be of interest for further reading. Thank you very much for your attention and enjoy the rest of the course.